Hello and welcome to another Sapient Care Group discussion. My name is Sanjeev Silva, head and neck surgeon. We aim to bring the big thinkers and experts from around the world, some with quite divergent viewpoints, to encourage us to think more critically about this pandemic and examine what our best response should be. Looking ahead and also looking ahead to see what sort of post-COVID world we will soon inherit after it. I'm delighted that today we are joined by two esteemed experts in the world of vaccine development. Professor Jerome Kim, Director General of the International Vaccine Institute based in South Korea, and Professor David Salisbury, Department of Health's former Director of Immunizations. I'm happy to hand over to our head of our steering committee, Professor of Medicine at Bristol University, Stafford Lightman, who will chair the discussion. Thank you.
Thank you, Sanjeev. So we're now in a critical phase in our response to the COVID pandemic all over the world. With the easing of the lockdown phase, politicians are talking up and down their vaccination investment programs. Will this be a long-term solution, or are we simply fooling ourselves? Well, to look at the reality, we're very fortunate to have two international experts on our webinar today. Jerome Kim is a physician and is currently Director General of the International Vaccine Institute in Seoul, South Korea. He's also Professor of Medicine at the Uniformed Services University of Health Sciences and Principal Deputy and Chief of the Laboratory of Molecular Virology and Pathogenesis at the US Military HIV Research Program. At the International Vaccine Institute, he's leading teams at the cutting edge of new technologies in genomics, immune monitoring, and machine learning in order to understand the mechanism of protective immunity with vaccines and immunotherapies, complementing our efforts to improve the health and well-being of the world's most impoverished populations. David Salisbury. David is trained as a pediatrician in Oxford and London. He was Director of Immunisation at the Department of Health until the end of 2013 and led the introduction of many new vaccines. He previously chaired the WHO's Strategic Advisory Group of Experts on Immunization, the WHO committee that sets global immunization policy. He also served as co-chair of the Pandemic Influenza Group of the G7 Global Health Security Initiative. So we have some great experts here to answer these questions. And to begin the webinar, Jerome Kim is going to give us an introduction, and he's going to give us just a short précis of Korea's successful response to COVID, including the vital importance of testing in response to the recent outbreak they've had there, and how this can only be a temporary phase until a vaccine is actually developed. And he's also then going to go on to give us a little discussion on the state of play in current vaccine development. So Jerome Kim, thank you very much.
Thank you, and good day. And so just briefly about what happened in Korea. And I think, people are all now know pretty well that Korea successfully overcame the initial outbreak of COVID-19. And they did this through a fairly simple system. The first was that the government had experienced an outbreak previously of a different coronavirus, of the Middle East Respiratory Syndrome coronavirus in 2015. And there was a lot of criticism of the government and the government's response. So taking that to heart, the government modified the Infectious Diseases Control and Prevention Act and basically gained several authorities. One of them was to establish a very top-down mechanism for providing messages and providing instructions from the Prime Minister, who heads the committee nominally, to the person appointed as the principal assistant for this. And that person, the deputy, is actually the director of the Korea Center for Disease Control, who holds the nominal rank of vice minister. So from the very top, there is a unified system of command and control, instructions and communication, and it's completely internally consistent. That was very important. The second part is preparation. So again, as a result of the outbreak in 2015, the government of Korea has had periodic exercises, tabletop exercises, responding to pandemic outbreaks and gathering academics from around the country to work with government officials to try to devise optimal solutions to a proposed question. And the last one was reportedly held in December of 2019 and involved a Korean couple returning from China with an unknown pneumonia, which actually kind of interestingly fit in very well with the outbreak that happened a little over a month later. The next part has to do again with the ability of the Korean government under certain circumstances, that under public health emergencies, to gain access to GPS information and credit card information. They put this law into effect. Again, this was one of the modifications that was made, again, after the outbreak in 2015, before the outbreak in 2020, fully discussed in the National Assembly, made law. And the reason for it was that the government felt that it was very difficult sometimes to get correct information from the people they were interviewing. So, if you talk to someone and ask, so where have you been? They might tell you one thing, they might tell you another. If they have something to hide, they might not tell you the right thing at all. And we've seen examples of that during this outbreak, that the GPS information and other information that the government can gather on an individual actually allows them to say, no, we don't think that that's true. And eventually, they get to where the person has been, what the potential contacts have been, and it allows the government to do that. But that change in the law happened in the intervening period between 2015 and 2020, and wasn't done at the height of an epidemic or an outbreak, because it's very difficult to have a reasoned discussion when you're in the middle of trying to respond and control an outbreak that you just found out about and you may not know a lot about. And then after that, it was widespread testing, tracing of contacts, isolation of people who were potentially affected or who were infected, and then appropriate treatment. And again, this was all a part of the pandemic plan, so that they had primary hospitals and backup hospitals. They could move doctors from one part of the country to another. I mean, all of this occurred as a country moved from the initial level. So there's no outbreak. There's, presence of an outbreak that the government is aware of, case in Korea, local spread, and national spread. And so each one defines a certain set of, activates a certain set of responsibilities and rights that the government has. And again, this pandemic preparation, I think, proved to be very valuable. So everyone knows Korea successfully eventually began to control the outbreak through widespread testing, and eventually, got to the, under 50 cases for over 3 weeks, which, was one of the government thresholds for beginning the transition from social distancing to what is now called routine distancing, removing some of the more severe restrictions on bars and gyms and nightclubs and churches, and really beginning to open the country again. And then, of course, another outbreak happened. And I think the government was expecting it. And, like all governments, they used the period where they were flattening the curve to gain time, to put the right things into place, to establish the best lessons learned, to set up the testing stations, to make sure that everything was ready for the time when they were releasing the restrictions. And when the outbreak occurred, it was a single person who visited several nightclubs in an entertainment area, and it resulted now, I think we're at 237 infections that have been detected as a part of that outbreak. Over 50% of those detected infections are actually not primary infections. So they're not the exposure to the primary case. These are secondary, tertiary, fifth order and sixth order transmissions. And some of them have been really fascinating, but they get to how this virus is transmitted. It went from the original person to a teacher who exposed students at the cram school that he teaches at, who then exposed another outsider at a karaoke bar, and who then exposed his father, who exposed people at a restaurant. And it's this kind of transmission which occurs as a result of everyday living. It gets to the idea that if you can get adequate testing and identify the contacts and their networks, that you may be able to understand where transmission is and when it stops. In order to identify these 237 people, Korea tested over 82,000, performed over 82,000 tests, which is a ratio of tests performed to number of cases detected of over 300 to 1. But if you look at the countries, again, that have been successful in controlling the outbreak, not necessarily Asian, Australia, New Zealand, they're all in the order of over 100 tests performed per case detected. And when you look at countries around the world, the United States is between, I think, 1 to 2 to 1 to 5, whereas Korea is over 1 to 50, and Australia, New Zealand, Taiwan are all over 1 to 100. So again, this testing really is an example of how tracing works and how isolation of potentially infected contacts works to limit spread. And that's where they are now. And I think we're going to expect to see additional outbreaks, and hopefully the government will clamp a lid on it before it becomes a major issue. I don't know if you have questions or comments.
Well, in terms of that, I mean, the fascinating thing about that for me was that that one person resulted in sort of 6 layers of people who were being affected. So, I mean, this really means that in order to find out who's been infected, you need a massive amount of diagnostic ability. Do you think that this is something that other countries have?
I think it's something particularly in high-income countries that could be instituted. But it also, suggests that I remember when the outbreak was first starting in the place where I'm from in the United States, they were able to do 1 or 2 tests at a time. So individual lab technicians would do a single, RT-PCR test. What the Koreans and other, like I think in New York now, they have this mass testing capability where a single person with the appropriate machine and automation, can do thousands in a day. And that's the kind of scale up and ability to test that you need in order to do this kind of work. I'm not sure, I'm pretty sure that in high income countries that you could probably set up a testing network like that and a tracking network like that. But again, countries have used the flattening of the curve period, the mandatory social distancing or lockdowns to better prepare for the time when, as everyone expects, we have to let go in order to let people get to work and for the economy to get moving again.
Well, thank you. I think probably now, if I could just ask you to move on to just give us an overview of what the state of play in current vaccine development is, and then we'll have, I'm sure, a lot of questions after that, both for you and for David.
Okay, so I mean, so at its simplest, vaccine development and utilization is fairly simple. You prove that it works, you make it, and you use it, and those 3 steps have an enormous amount of complexity under normal circumstances when we have 5 to 10 years to develop a vaccine, and then years after the vaccine is marketed to get the vaccine used in the community and then used globally as WHO and SAGE issue recommendations for use worldwide. That's now all compressed to 12 to 18 months. And so those things that we would normally do in parallel, sequentially, are now going to be telescoped and compressed. And it's a huge amount of work and a huge amount of now planning. I mean, we have 8 or 9 candidates now in either in or soon to enter human clinical trials. As we prepare for manufacturing, do we have to prepare manufacturing for each of those vaccines? So will you have to teach, 8 different or groups of manufacturers to make each of those vaccines in large quantity? Or do you pick 2 or 3 once they enter the final phase 3 of testing and have the manufacturers ready with tech transfer and getting ready to scale up in anticipation of a positive result? So, and then after that, you have the even bigger question, and I think David will get into this also. how are you going to ensure that as the vaccine manufacturing is ramping up, that appropriate populations that are prioritized are going to have access to the vaccine in countries around the world where burden is great, and how are we going to make those decisions? And I think, I mean, many people have been arguing that we have to start those discussions now, because if we do it when we have a vaccine that is already shown to be safe and effective, it's going to be nearly impossible to have a reasoned discussion or a reasonable discussion.
Just before I bring David in on this, one thing I'm really not clear about is how are we going to, with all of these vaccines, how are we going to decide which vaccine is best?
Yes, so that's a great question. And it gets to some of the issues that come with the infodemic that we're in now. Actually, I hadn't heard of the term until very recently, but it really does encapsulate the problems that we're having as scientists and as clinical developers. I mean, so initially, right, we normally test a vaccine in animals, and if it gives you the right immune responses, then you pick the ones that you think might be the best, and you move them into human clinical testing. You do phase 1, it's safe. You do phase 2, you may have to go back to the drawing board or change the dose or change the frequency of dosing, and you do all of that, in a series of clinical trials, and we have time. And then we look at the immune responses, and then usually a company or maybe the Gates Foundation or the Wellcome Trust says, okay, this is the dose, this is the vaccine, this is in the right target population and it works, let's take it into phase 3. Right now, the pressure is on so that we haven't necessarily seen all the animal data on all of the vaccines. We've seen human data, published human data on 1 of the 9 vaccines. We've seen we've seen a report of human data in the news media of 8 out of 45 people in a single phase 1 study. This is the Moderna vaccine, of course. And we have a report that it makes neutralizing antibody not at a particular titer, but at a level that exceeds that normally seen in COVID-infected people who are convalescing. And I know, David, you're probably thinking the same thing. I look at this and say, well, that's good news on the one hand. I mean, it's positive. On the other hand, I'm used to seeing the data. And, we're making these judgments. We have monkey studies. Not all of them have been reported. Almost all of them, I think, show or reported to show protection and no evidence of any safety signal. But, the number of monkey studies that has been published is one has been published, one is in preprint form, and one is by report. Oh, actually, it's for a vaccine that is not entering human clinical testing. So how do this infodemic, I mean, we're getting information that's unfiltered and that we're having to interpret. And you may have someone talk about the Oxford vaccine and say, it's great, it protects monkeys. And then another person say, well, it may protect against pneumonia, but it doesn't protect against transmission because we find evidence of the virus in the nasal cavity of the monkeys where the inoculum was inserted. And what do we do with that? So, sorry, go ahead.
Well, can I just say, if world expert like you and David can't make sense of the information that's available because almost none of it's published, and this infodemic, and then certainly the population, politicians or the population in general, I can understand why they would be very confused about understanding what's happening in vaccine development. But can I just move on a little bit now, and I'll move to David at the moment. There's first of all, what actually is the world capacity for vaccine production? And there's this huge question of equity, because clearly there's going to be a limited supply. And it gives us 2 questions. First of all, within a country, who should get the vaccine first? And the second one linked to it is to ensure global good. Who should the vaccine be made available to?
Well, I think you had at least 3 questions in there. Let me start with the first one, which was utterly unanswerable when you said, what is the global capacity for vaccine production? That depends entirely on what vaccine. It depends on whether it's an established vaccine, if it's a vaccine whose capacity can be easily increased, or if it's, as in our current circumstances, a new vaccine. Now, if you take a sort of parallel, and that is to an influenza pandemic, and then ask what is the capacity for vaccine, the answer is much easier. We know how to make influenza vaccines. We know which ones work. We know how to test them. We know how to license them, and we know how to manufacture them. And what we don't know is what is going to be the influenza virus that will cause a pandemic. Now, if you go back into the early 2000s when we were worried about H5N1 virus, then it was much easier. We already had candidate H5N1 viruses that just hadn't turned pandemic. And therefore, we could start to work out how to make vaccines against it. And we got to a point where, with, I think, great foresight, the European Medicines Agency came up with a scheme for licensing such vaccines, where they said, make a vaccine against one of these early strains that might be pandemic. And then, when the actual virus emerges, within 24 hours, based on the data that you've already given us of how you're going to make the vaccine, we'll give you a license. Now, we are a whole world away from there in our current circumstances, where we know the virus, we know the sequencing, but we haven't got a clue which of the many, many candidate vaccines are going to be safe. And sadly, a phase 1 trial does not tell you about safety. All it tells you is that nobody actually fell down dead when you gave it to the 10 people or whatever that you've given it to. Safety is a much, much bigger issue than just what you get from a phase 1 trial. And even a phase 2 trial doesn't tell you about rare adverse events. So we have to be very cautious about how we will learn about safety from these accelerated trials. And then we have to know about whether it's going to be effective. Now, with an influenza vaccine, we didn't have to do efficacy studies because we knew what the correlates were that tell us that a vaccine antibody result will predict reasonably the efficacy. We don't have that at all. So whilst at this stage, we are trying to do phase 2 studies of looking at the antibody responses, we don't know yet if they will protect, how long they will protect, how many doses you're going to need to achieve protection. And some of the most fundamentals are still unknown. And the limited information that we've got doesn't yet give us assurance that you will get sterilizing immunity so that the virus is actually killed by the antibodies that you produce. Because if they're not, if the viruses are not killed and you still can be infectious, well, actually that hasn't contributed a huge amount. It may have given individual immunity, but it will not actually give community immunity. So we face some huge problems in what vaccine. And you say, how do we choose? Well, I don't think any of us know yet how we will choose, because these could be 8, let's just say there are 8 leading candidates. It could be 8 very expensive mistakes, anywhere from 8 down to 1. And we could have 1 vaccine that works and 7 that don't, and 7 manufacturers will have a product that they can't use. For influenza, we had capacity, and we knew that if we adjuvanted the vaccine, we could multiply up the capacity. These are unknowns as yet. So there are huge technical problems. Jerome said it very simply. There are 3 issues. You know, what is the vaccine? Can you make it? And can you administer it? But within each of those, there are huge complexities. You then moved on to your second question, which was, or I'm going to move on to your second question, which was, within a country, who are you going to give it to? Actually, I think that's one of the easiest questions of the whole of this dilemma that we face. You would give it to the people who are at highest risk. And we know very clearly now the profile, I believe, of the people who are at highest risk from this particular virus. And it's people who are in the older age groups, people who've got medical comorbidities, and particularly hypertension, particularly diabetes, morbid obesity, are clearly risk factors that you would prioritize. And then people who are at high risk because of their occupation, and here we've got healthcare providers, and we've got people working in the in the care sector clearly are at an element of increased risk, although I think that the quantification of that risk remains still to be elucidated. So we can reasonably pick up a list of the people who you would prioritize. And actually, suddenly, that gets quite easy because we know who those people are. They're the people who are on the flu vaccine priority list. So the actual identification of who to prioritize is, I believe, easy. And then the second question, of course, that follows on to that is, well, can you vaccinate them? And in this country, I think the answer would be yes, we can. We have one of the world's highest uptakes of seasonal influenza vaccine. And it's administered through primary care, and it's done with very considerable efficiency. So could we do that? I think the answer is yes. And let us imagine, and I think this is a tall order, let us imagine that this vaccine came available from September onwards in quantities of, let's just imagine, if you needed one dose, we'd want something like 20 million doses. And if you had to give 2 doses, you might want 40 million doses. And lo and behold, that would be the time of the year when we're vaccinating against flu. So you could see a system quite easily in this country where you would vaccinate against COVID at the same time that you vaccinated against flu, maximizing the opportunities that come from flu vaccination. Sounds simple, but the regulators are quite likely to say, could you do a study, please, on co-administration of seasonal flu vaccine and your new candidate vaccine so that we know that the two will not interfere with each other? Well, seasonal flu vaccine doesn't become available till about August, September. So those trials suddenly can't be done until we've got flu vaccine to be able to co-administer it with this vaccine. So the administrators might take a rather lower bar and say, okay, we don't know of problems with interference, so go ahead. But they could say, no, we need to know this. And then suddenly, what sounded like a brilliant idea means that you can't run the two together. So within countries, I think we know who. In this country, we know how. However, most countries in the world cannot match the UK seasonal flu vaccine uptake. Many European countries with sophisticated health services have useless seasonal flu vaccine programs. And so whilst the idea is good, the implementation may not necessarily be so good. Your third question is, what about equity? What about the rest of the world? Well, just using our flu model, middle-income countries and low-income countries do not have established, efficient vaccine programs for older adults, healthcare workers, and the people who we know are in the risk groups. They have often very good programs for vaccinating children, but they don't have programs for vaccinating other people. So how would they do that if the vaccine was available? And that's another question we have to come back to. Let's just deal with how would they do that? Well, they have no adult immunization program, so they're going to have to implement one. So who would you use to do that? Well, you might use the people who know how to give vaccines, and that's the people who give the childhood vaccine program. That's not straightforward, because now we have to give them 2 jobs when they were already fully occupied with one, and that's called an opportunity cost. So what else won't they do at the time when they are giving this vaccine as well as childhood vaccines? Now, we already know the answer to some of that. The impact of COVID-19 has already been felt on routine immunization programs. In many parts of the world, they are not being implemented to the same extent that they were before. So even before we've asked people to vaccinate people that they didn't used to vaccinate, they are not delivering childhood programs. So move them to vaccinating high-risk adults, and they may not be able to vaccinate children. So whichever way we turn, we face multiple problems. And that doesn't even address the question of how will we divide up the vaccine production that we hope we will have from as many successful vaccine candidates as emerge from this race? I'm happy to go into that, unless you want me to pause at this time.
Well, can I ask you something slightly related first? So what happens if we have a world in which some countries have a very successful vaccination program and others don't? So because presumably we're not going to be able to deal with COVID until the whole world's dealt with COVID.
Well, we already have that situation that some countries have excellent vaccine programs and some don't. And that takes us into very difficult territory. If you had a vaccine, and however successful production is going to be, it will be limited in its availability. That's a given. Would you give it to countries where the disease was entirely under control and there were no cases? Or would you give it to a country where disease was rampant and their health service was almost overwhelmed by clinical cases? And I think that there are dilemmas in whichever way you choose to go. If you choose a country where there are no cases, you may have capacity to administer a program. And that ignores the people who are currently overwhelmed by disease. But if they are overwhelmed by disease, do they have capacity to vaccinate? So I don't know the answer to this. I don't know whether we should prioritize those who are currently out of trouble because they have the capacity to implement a program, or do we prioritize those countries who are in dire need of controlling the disease because they're suffering at the time? Now, perhaps there is some sort of compromise amongst all of that in prioritization, but that will depend on capacity. Every single thing that we choose from here on in who gets vaccine will be driven by capacity to produce vaccine. And the capacity is a function of time. And everybody seems to forget that capacity is a function of time. It isn't whether your vaccine can make 500 million doses. It's how long it takes your factory to make 500 million doses that defines what you will do with it. And I don't think we've even started to open that particular topic for discussion yet.
And where in the world is there the capacity actually to make vaccines?
Well, there's nowhere in the world with capacity to make this vaccine. There are places in the world with huge capacity to make existing vaccines, and Europe is one of the biggest producers of vaccines amongst a number of countries in a number of companies in a number of countries. So we have Europe, we have the United States, which has huge capacity, and India in particular also has considerable capacity, and Indonesia also makes some vaccines in large quantity. But none of those have got factories sitting idle that have got exactly the right type of manufacturing sitting waiting for a COVID-19 method to be put in place and tomorrow start producing. I think people are hugely underestimating where vaccine will be made, how it will be made, and how quickly it will be made. And when people talk about, let's go to a greenfield site and build a factory tomorrow, I believe they are being horribly naive.
Well, David, that's a dose of absolute reality, which is critically important for us. I wonder if we could go back to Jerome a little bit now and ask him a little bit more about how much we can actually trust the specificity and sensitivity of the antibody tests which are becoming available and how we should actually be able to interpret them.
So I'm probably not the right person to ask a diagnostic question like that. I mean, it's really going to be important that as they look at these tests, that they test the right samples. So not only do they need people early in infection, so maybe at day 3 or 4 or 5 after exposure, or when the RT-PCR just turns positive, because we really need to understand what the sensitivity and specificity are, both early in infection and late, particularly if they're going to be used in diagnostic mode. If they're being used in screening mode, in other words, to tell the level of infection in the population, then it's probably less necessary, but it's going to be important to know what the level of cross-reactivity is with circulating endemic coronaviruses. And I'm not sure that we have the perfect test yet. I mean, I know that I guess Spain has used a test, and the Swedes are rolling out a test, and at least one group in the United States has a test that looks like it might be pretty good. The group at Mount Sinai in New York. But we really need to see all the data, and really the governments like the Food and Drug Administration, the EMA, the NIBSD need to have these large panels so that we can really understand how sensitive and specific these assays really are. And they should be well qualified so that we can compare between assays. Because again, the last thing we want is to have an imperfect assay and use those imperfect assays to make an attempt at policy decisions. Again, and it matters a lot. I mean, if you think that the last Spanish survey showed that only 5% of Spaniards had been infected, and you then think that 95% are potentially susceptible, that has huge implications for a government that may be thinking about what is the acceptable level of risk for letting this pandemic run freely through the population and achieving whatever that level of herd immunity is that they believe is necessary. The test is really critical.
So is there any question that you might be able to be protected against a viral challenge actually without an antibody response?
I suppose that that possibility exists. Until we do a human challenge, it's going to be difficult to know because we won't necessarily have markers. I mean, you could be screening people for positivity on the basis of the PCR assay, but then at the same time be looking at antibody assays. And so you would be looking for exposed and quote uninfected individuals. And that's actually a relatively difficult thing to prove because you can do it experimentally in challenge studies. So maybe the Oxford group might be able to do a human challenge with COVID-19 if that were found to be scientifically and ethically acceptable, but it's difficult to make that judgment in the absence of information. You may be able to do it with a monkey study. But again, I'm not sure how you would necessarily prove it to the satisfaction of people and how important would it be that we have to have something that we can measure that is robust and reliable so that we can make either policy decisions or, if we're doing a vaccine study, those people who have pre-existing SARS-CoV antibodies could be excluded from the final analysis because they were, quote, already protected. But again, you want to make absolutely sure that you knew that your test was sensitive and specific.
David made a point which is sort of worrying, that you might land out having antibodies that are enough to stop you giving symptoms, but you could still then be a carrier and you could still be passing it around all the time. And so that actually giving a vaccination might actually increase the number of people who are actually be able to spread the virus around.
So that was one of several really interesting points that David made. And it's absolutely true, but I think you have to think about what your end in mind is. If you're vaccinating people in nursing homes, you want to protect them. If they spread it to other people in the community, that's not necessarily fine, but you are protecting the population that is at the greatest risk of severe outcomes from the disease. If you were vaccinating the entire population or a certain number in the population, then the question of vaccinated people potentially spreading infection could be an important one and would be something that we would need to look at and maybe try to model. But again, I don't know, David, have you thought more about that question?
I think it really is a very difficult issue if we don't know who is indeed immune and who is susceptible and how long they remain immune and when they become susceptible again, because clearly it will define your vaccine program, whether this is something you'd have to repeat every 6 months, every year. And we simply don't know either what the periodicity is going to be of this particular virus. Will it come back in the autumn? Will it come back in the winter as if it was influenza? Or will there be long intervals? And will the virus itself mutate to a less severe or more severe form that escapes from vaccine protection? So I think there are a huge number of unanswerable questions, and we will only find as we go what are some of these particular answers. And we may find at our cost if we get some of these wrong. I think there's another issue, just to go back to the very testing question that you asked about the sensitivity and specificity of the tests. Clearly, for the tests of immunity, we need to see the published data. We need to see these as comparative data. But there are also real risks for tests that the public may wish to avail themselves of if we don't know whether they are actually sensitive and specific, because that will change people's behavior. If you go along and get yourself a test off the internet and you administer it home and you say, oh good, that means I'm immune, that may well change your behavior. And it may change your behavior in a way that actually adds to risk to yourself and to other people. So I don't think we know yet how much we can do on community testing that allows the community to test themselves, as well as it being available for research purposes. Thanks.
So, I mean, between you, both of you are basically saying, I think that we should be making plans for what we're going to do if there isn't going to be a vaccine readily available in the short term. So maybe I could ask both of you what you think those longer term plans should be. Maybe Jerome, can I start with you?
So speculation is always a dangerous sport, but you know, so I think that we will see. I mean, so a country like Korea, which has the epidemic relatively well under control, the outbreaks relatively well under control, will probably see intermittent outbreaks, and we'll try to jump on top of them very quickly. But at some point, the government will need to open up business, which means opening up travel, which means restoring relationships that were cut during the pandemic. I mean, we can do a lot with virtual meetings and et cetera, but it's been difficult for certain, and for instance, for vaccine work, to not be able to visit a site in which you want to conduct research. So there are things that will have to happen. So I would expect in a country like Korea, they will expect a certain level of, there will be outbreaks. How do you deal with it in a country like the United States, where the epidemic is under imperfect control and differs from state to state? And how will you, do you just resolve to let nature take its course and achieve herd immunity one way or the other, knowing that in a country that large, that geographically dispersed, that this epidemic could go on for years if it's imperfectly controlled? And and the idea that the intensity of the epidemic for instance in Spain, because I saw the antibody data that appeared on the internet. The intensity of infection there and the number of deaths was tremendous, but only 5% of the population maybe was exposed. If that's true, then this epidemic will persist in that population in a series of waves, as has been predicted before. And we really don't have good. I mean, models are based on assumptions, and what assumptions do we use? And so when you look at the epidemic predictions, the curves are dramatically different depending on the assumptions that are made. And as David said, we don't know the answer to a lot of these questions. Maybe we'll put our heads down and vaccinate as many people as we can, but that isn't a solution either, because our knowledge is imperfect, and that makes our solutions imperfect.
David, have you got some thoughts on this too?
Yes, and I'd take a different slant on this to Jerome's. And just coming back to what he said, SARS did not become established on a global basis with regular waves continuing. It did seem to sort of settle down. So we simply don't know what this virus will do between turning into a seasonal virus like influenza and coming back and back and back, or turning into a different sort of pattern. I don't believe we know that. The direction I would like to take, though, is different to what Jerome said. I think we have to have as much research as possible on antiviral treatments, because producing an antiviral, once we knew that it was safe and effective, would be much more straightforward than making vaccine. Vaccines are biological products that are notoriously difficult to make consistently, and you can't actually tell that you have made it entirely against the recipe until you get to the end of production. And so the testing that is done, although there's a lot of testing done in process, you can't release the product until you have finished making it, and you then have to test it to make sure that it's going to be safe and it's going to be effective. Whereas producing a medication such as an antiviral may be much more straightforward, much more scalable, and much more transferable, so that the capacity to make antivirals may be very much greater than the capacity to make vaccines. To test an antiviral, you basically want to show that people who are ill get better when you give it to them, obviously compared to a controlled population. But you don't have to do what you do with a vaccine, which is to give it to a very large number of people to make sure that some of them don't get infected. So the scale of testing is completely different. And the quantities of an antiviral that you would require are going to be quite different, because you only give them to people who are ill, ideally at an early stage of their illness so that they don't get more ill. But nevertheless, you're not having to give them to everybody to protect everybody. And therefore, I think that we should be really working flat out, and I'm sure everybody is, because whilst vaccines may be fantastic at protecting us, antivirals well targeted may actually be an easier solution. I don't know if Jerome has a view on.
Well, Jerome, can I ask you, because I mean, Jerome, you've got the background in HIV research that you did in the States, and presumably this is what happened when they couldn't find a good vaccine against HIV. So presumably that experience should lead you as partially down thinking in those lines as well.
No, I agree, and on the one hand, with David's proposition that we need to work as quickly as possible on safe and effective antivirals. I'm not sure that the model necessarily works, because we have safe and effective antimicrobials. It doesn't necessarily take us all the way. Having an effective vaccine, I think, is a complement. In fact, in HIV, we say having a vaccine would be a part of a full public health solution to a problem that includes both treatment and prevention. So I agree that we need to work as quickly as possible on antivirals. I'm not sure that we can treat our way out of and there's also, I guess, again, based on experience with HIV, and we're hoping that COVID-19 will not end up the same way, there's the issue of resistance, which has emerged for antimicrobials, which has emerged in HIV, which mutates a lot more quickly than SARS-CoV-2. I think that if we ignore one of the arms, either prevention or therapy, we subject ourselves to potential risk. I would even put forward, so again, based on experience in HIV, people talk about monoclonal antibodies as a potential longer-term solution. And they're working through, lower cost production, longer lasting monoclonal antibodies. I mean, yes, these are not necessarily far-fetched, but, when we think about the cost of a monoclonal antibody, we're thinking, at least in the United States, thousands and thousands of dollars per treatment. But as people at the Gates Foundation are looking at this is a scalable problem that may get them to the point where they can have an injectable cocktail of monoclonal antibodies that may prevent HIV infection for long enough periods that a woman or a man would need to go in every 3 months for dosing. So again, I think we need to pursue all of these because we don't know at this point which one will work. And for instance, even if we did have a safe and effective vaccine in February of next year, for instance, it would still be useful to have a cocktail of monoclonal antibodies to give at the same time as the vaccine, or to give to people that we needed to have, like say healthcare workers in Tanzania. But we didn't necessarily have enough vaccine to reach them right away. Or if we had people who needed to travel, we could give them a dose of the monoclonal antibodies or maybe high titer plasma. But again, we shouldn't ignore any of these potential therapeutics or preventive reagents.
Do you want to come back on that, David? Is there anything else you want to add to that?
I don't disagree at all with that. I mean, we need to have everything that we possibly can have in our armamentarium, and we need to use all of those creatively, flexibly, to all of their particular strengths. There are a lot of advances being made now in monoclonals for other viral infections. And I think that clearly people will want to build on those new knowledges and those new productions. Antivirals, I accept fully the issue of resistance and that it may be much more difficult than I have made it sound. But we have to have as much as we possibly can without thinking that overnight we're going to have a vaccine in the quantities we need at an affordable price and available to everybody in the same amount. I think that's optimistic.
Maybe I could finish by asking both of you something that worries me slightly as a non-COVID scientist, and it is the amount of unfiltered science, which you call has been called the infodemic that's going on. And my worry is that the general population are being very confused by political leadership saying everything they're doing is being led by science. They're doing this because that's what science tells them to do. But of course, science doesn't tell people what to do. It gives experience, it gives advice on which decisions are made. But I'm more worried by the fact that this infodemic is giving the idea to the general population that we know lots of things that we don't know. And I just would be very interested in your take of the dangers of this infodemic, and if there's anything we can actually do to change it or change people's appreciation of what science actually can do. Maybe can I start with you, Jerome?
Okay, this is a tough one. So, I've known Dr. Fauci for a long time. I've never seen anyone, do personal attacks against him. Getting scientists involved in this way, in what are often seen as political decisions, really puts us in a difficult place because, we don't want to say, we know the answer. We know that people who are infected by COVID-19 are going to be immune from reinfection. We don't know that. And we've, really known about this virus for a bit over 4.5 months, which is, remarkably short period of time from a scientific perspective. And so we're being put in the position to to speculate on what we know and to extend that into areas where, again, we're taking a guess and we're extending it and extending it again. We have, on the other hand, people like Dr. Fauci or the people who are advising Scott Morrison in Australia or, the Prime Minister of New Zealand, and providing them with what they thought was their best possible advice and making recommendations that the government implemented. And, but again, we recognize, I think, as scientists and clinicians that, a lot of what we do we make recommendations based on the information we have, driven by the intensity of the pandemic. But knowing that we may not necessarily be making the right recommendation if circumstances were different, if the models look different. And it's difficult for a non-scientifically oriented person to understand the nature of doubt in science, or no one's received that packet of questions from a reviewer that's 4 pages long, highly detailed, that changes the nature, that shapes the nature of the paper and the conclusions that you draw and the way you state them. And those are so critically important for us. But it's absent when, you know, a reporter from the New York Times asks you, so Professor Salisbury, what do you think about, and you know, you haven't read a paper, you know, someone has talked about it in a press conference or in an investors meeting, and what do you say?
Well, David, can I put you, I mean, the classic of this at the moment is the AstraZeneca new vaccine, which they've talked up enormously. And they're saying there's someone in America who wants to take on a whole lot of it as well, and how marvelous it's going to be. I mean, what's your take on this, and what should we as scientists be doing to actually get people to understand the reality of the situation?
Well, let me just fall back onto what Jerome said, because I agree, of course, with what he said. I think there's another dimension to it, and that is that we are accessing results, and not necessarily in as much detail as we would like, in extraordinary short term. And we have to go back, I think, and credit the Chinese for releasing the sequence of this virus as early as they did, and then look at the unbelievable quantity of information. Now, of course, in many views, it's too much, and it's unfiltered insofar as it hasn't necessarily been refereed. But the amount of information that the scientific community can look at to try to make best judgments is unprecedented, to have this much, this quickly, this available. And it may well be a really important factor in defining what pieces go forward that will change all of our lives, which would not have happened if we had to go through all of the processes that have had to be held to in the past. Now, you raised the issue of the Oxford vaccine and AstraZeneca, and clearly there are huge risks here. Any government that puts all their money on one vaccine risks that product actually being one of the failures, and there will be failures. So what do you do if you are a government when you simply have only got the words of enthusiasts and some background experience of other things that they've tried to develop to say, this is the one for us? Now, you can take a number of approaches. You can say, we're going to put all our eggs in one basket, and we're going to be absolutely confident that this product can be made in sufficient quantity for our country and it will work. But that is really high risk. I mean, on what have you based that when up to date, there's no evidence to tell you that was right? Alternatively, you spread your bets and you say, we will make an investment in 8 companies and we'll only get 1/8 of the quantity that we need. So whichever way you turn in this, the difficulties are enormous. And telling the population not to worry because we will have a vaccine, and I'm not saying people have done that, but nevertheless, if you were to say, we will have a vaccine as fast as it can be produced, well, it needs some pretty strong caveats around that. Yes, as long as it works is one of them. So these are tough decisions.
Well, thank you. We're coming to the end of the webinar, but maybe I could ask both of you just to sum up what you think you would hope the best things that we can do over the next few months. So what you would like the world to be doing over the next few months to help the best possible outcome to the situation that we're in. So Jerome.
So I think that for now, countries around the world need to focus on control efforts, on using mechanisms at their disposal to try to limit the spread of SARS-CoV-2 in populations within their borders. I think that the reason for that is that we will probably have this virus for some period of time. and that the goal here is to limit bad outcomes in highly susceptible populations, and to give us time to develop a vaccine, to develop new drugs, monoclonal antibodies, because even though we show that it works, it will still be some period of time before enough of whatever intervention is available to be effective worldwide.
David?
Well, Jerome has said it very eloquently. My hope that we have at least 8 producers of safe and effective vaccine who can produce enormous quantities almost overnight, and it can be made available to everywhere that it is needed, wanted, deserved, and afforded.
Well, I'd like to thank both of you very much. This has been an incredibly informative webinar. It's been extremely useful, and I'm hoping a lot of people will be able to listen to it to actually get a realistic view of where we are in the world of vaccines and in the treatment of COVID. Sapient Care has put this on, and I'm very grateful for them for having organized this webinar. But as I say, particularly, I'd like to thank both of our speakers very much for their extremely enthusiastic, helpful, and informative discussions. Thank you both very much indeed. Goodbye.
Thank you.
Bye. Thank you.